broad term to describe the treatment of cancer and is most often used to mean the non-surgical treatment of malignancy. These non-surgical treatments include radiotherapy, chemotherapy, hormone drugs, targeted drugs, and supportive medications. They can be used with the aim of trying to cure a cancer, or if incurable, controlling the cancer for as long as possible and helping to relieve symptoms caused by the cancer. How they're actually used will depend on the type of tumour, its stage, and the patient's medical history and wishes. In this programme, we hear from Professor James Jorgensen, Chief Pharmacy Officer and Vice President of Indiana University Health in the United States. Mr. Jorgensen discusses the importance of protecting healthcare workers from exposure to hazardous drugs used in the treatment of cancers. Mr. Jorgensen describes how the 12 oncology infusion centres at Indiana University Health are using the closed-system drug transfer device developed by BD Medical. This device is used for the preparation and administration of all chemotherapy agents, including monoclonal antibodies. We also hear from radiotherapy innovators Oncology Systems Limited and Varian Medical Systems, who explain how their continual research and development provides the healthcare sector with state-of-the-art technology for the best possible treatment of cancer. Next on NHS Advances in Oncology is a report on Handle with Care healthcare worker safety. This section is presented by Christine Clark, pharmacist and freelance writer, editor of Hospital Pharmacy Europe. Over to you, Christine.
Thank you, Georgina. Joining me today is Jim Jorgensen, Chief Pharmacy Officer and Vice President of Indiana University Health. Jim, I understand that IU is the largest and most comprehensive facility in the state.
It is. IU Health is comprised of 19 hospitals, ranging in size from 15-bed rural hospitals all the way up to 1,000 beds. It's anchored by Indiana University Medical Center in Indianapolis, which also includes the Indiana University Health Simon Cancer Specialty Hospital, Riley Hospital for Children, and then a number of ambulatory clinics, which include 12 oncology infusion centers, and we're scattered throughout the state.
Tell me about the importance of protecting healthcare workers from exposure to cytotoxics.
Well, I think at the most basic common sense level, if you look at the issue, the same mechanism that these drugs use to kill cancer cells also damage healthy cells. So of course we're concerned about making sure that that exposure isn't present in our healthcare workers. And there's more drugs than just cancer chemotherapy that are considered hazardous. The World Health Organization came out with the first definition of what constitutes a hazardous medication, and that's been picked up subsequently by a number of professional groups, including the American Society of Health System Pharmacists. A drug is considered hazardous if it hits one of 6 categories. So if in small doses, the drug exhibits one or more of the following characteristics, so that if it causes reproductive damage, if it can cause developmental or teratogenic damage, if it can cause genetic damage, if it's carcinogenic, or if it causes end organ damage, it's considered hazardous. Or if it's a new drug and it's similar in structure to a drug that's already been proven to be hazardous, it's also considered hazardous. Previous to about 1970, as I mentioned, there wasn't a lot of attention being paid. But then we started to see more and more reports in the literature of side effects similar to what we were seeing in our patients showing up in healthcare workers, predominantly oncology nurses. So we're seeing those same kind of acute side effects of hair loss, mucosal sores, skin irritation, nausea, vomiting, dizziness that we would see in patients. And then as we began to look at this more, we started to see more and more literature reports of long-term effects associated with those 5 categories: reproductive damage, end organ damage, cancer, genetic damage, and teratogenic events occurring in healthcare workers. That promulgated a wide variety of standards to improve safe handling. So organizations in the United States, such as the National Institute of Occupational Safety and Health, Oncology Nursing Society, American Society of Health System Pharmacists, to name a few, and then internationally, groups such as the International Society of Oncology Pharmacy Practitioners have all continued to come out with enhanced standards around safe handling. Now, there's a number of standards, as I mentioned, designed to help protect us, but I think probably some of the most comprehensive are the ISOP, or the International Society of Oncology Pharmacy Practitioners standards, because those were a cooperative effort from around the globe. So the standards committee comprised 14 pharmacists from a variety of different countries, And they were actually charged with compiling all of the standards and guidelines from the various countries into one comprehensive document. And I think they came up with a very eloquent approach to safe handling, where they adopted a hierarchical model from an industrial hygiene, where they looked at doing the most safe thing you could do and then working down to the least safe thing that you can do. And I think too often as healthcare practitioners, we start at the bottom and work up. So if you look at the ISOP hierarchy, the first thing that they suggest is don't use the hazardous agent or substitute an agent that's less hazardous. But of course, with cancer chemotherapy, you can't really do that because they're all hazardous. The next thing that they suggest is contain the hazardous drug so that it never gets into the external environment. That would be where closed system drug transfer devices come in. And then you step down to what they term engineering controls, which are really primary engineering controls, which would be compounding aseptic isolators or biological safety cabinets, so that if the drug did make it out of a closed system, it would be contained in the primary engineering control and vented to the outside and rendered harmless. And then you have secondary engineering controls, which would be the negative pressure room that the isolator or biological safety cabinet is located in. So if it made it through the first two fail-safes, the room would contain it and vent it. Then you go down another level to the policies and procedures that we all employ for safe handling. And then finally at the bottom of the hierarchy is the personal protective equipment. So if it did make it all the way through, hopefully then it would minimize any operator exposure at the end.
So with all these measures, why is drug transfer safety still important?
When I was at the University of Utah, I actually had the unique experience of being able to build and design 2 pharmacies dedicated exclusively to the production and distribution of cancer chemotherapy agents. And they were a well-funded endeavor, so I had the opportunity to over-engineer these pharmacies and build them up to all the current levels of standards. This was prior to the introduction of closed system drug transfer technology, however, so when we built them, I decided I would test them. So we did surface wipe sampling in the pharmacies and in the patient care areas after 3 months of operation, and we looked for cyclophosphamide and ifosfamide. And what we found was that 100% of the samples in the pharmacy and in the patient care area were contaminated. They showed evidence of one or both drugs. And then we actually took that one step further, and we did 24-hour urine collections on all of the nurses, pharmacists, and pharmacy technicians working in those areas to see if there was any evidence of biocontamination in the healthcare workers. And what we found was 100% of the nurses had measurable levels of one or both drugs, 100% of the pharmacists had measurable levels of one or both drugs, and 30% of the technicians did. And we were deploying all of the current standards. So that said to us that despite our best efforts, it wasn't enough. There's been a number of studies that have actually used fluorescein dye as a surrogate marker for chemotherapy. So they've simulated chemotherapy manipulation and administration and then photographed the results under UV light so you can graphically see any evidence of contamination. And you can clearly see evidence in the biological safety cabinet, in transport vehicles, in work surfaces outside the pharmacy, and then in non-traditional surfaces like sinks and telephones. Again, illustrating that once this stuff gets out, it migrates everywhere.
Describe for me BD's closed system transfer innovations.
I think there's a number of products on the market right now in the closed system sphere, and I think that's great because the more products it helps raise awareness around safe handling. BD is unique though in that it has the majority of clinical studies to document that it meets the NIOSH and ISOP definition of closed, as well as that when it's added to a complete safe handling system, it helps to minimize or reduce exposure. The accepted definition for a closed system transfer device is a device that mechanically prevents the entry of contaminants into the system or the escape of drug or drug vapor out of the system, essentially a system that's leak-proof and airtight.
And how are you using FACEAL in your institution?
We've decided that we are going to deploy the BD FACEAL unit across all of our organizations that handle cancer chemotherapy. So we've got it in all 19 hospitals, and we've got it in all 12 of our infusion sites. So we use it in the pharmacy for preparation of all chemotherapy agents, which includes monoclonal antibodies for us, and we use it in the nursing areas for administration of those agents. And that also includes areas where we're using chemotherapy agents for non-cancer patients, such as dermatology or rheumatology or obstetrics. And we also use it in our investigational drug service, where we're working with any investigational products that we would deem to be hazardous as well.
Are there any additional benefits to the BD Facile device?
I think to date, most of the literature worldwide has focused on the second part of that definition, the escape of drug or drug vapor out of the system. But we've started to look at the first part as well, the prevention of contaminants entering the system. And our real impetus for that was drug shortages. We're facing a real crisis right now with well over 200 drugs in shortage situations, and that can be an absolute shortage where you simply can't get any more drug, or a relative shortage where you can't get as much as you need. And 22 of the drugs that we're tracking right now are cancer chemotherapy agents, and many of those are single-use vials. And in the United States, we practice to the United States Pharmacopoeia Chapter 797 standards on safe handling. And they stipulate that if you open a single-use vial outside of ISO 5 air conditions, so outside of a biological safety cabinet or isolator, you have to throw any leftover drug away after an hour. If you open it and maintain it in ISO 5 air, though, you can use it for 6 hours, and then you have to discard the drug. So clearly with drugs that are in short supply, where we don't have enough to treat all of our patients, we're not real excited about throwing away product that's chemically stable because we may have contaminated. But the USP gives you the opportunity to extend the beyond use dating for those drugs, the BUD, if you have documented evidence that you can safely move that beyond use dating out. And so we've focused on using the BD Facile product because it does maintain a closed system to extend that beyond use dating, allowing us to use more of the product without having to throw it away. That helps with drug shortages. The second thing that we found as an offshoot of that is it helps reduce waste significantly. In the United States, because of that requirement of 6 hours or 1 hour, we end up throwing away a significant amount of drug product that's chemically stable. And in studies done at the University of North Carolina and our own studies, that could be up to $1 million per institution. So if you extrapolate that out across the country, that's probably billions of dollars of drug every year that's chemically stable that's being thrown away. So there's a big opportunity for us to actually deploy the BD Facile system to help reduce waste, as well as extend our ability to use more of the drug in those shortage situations.
I'm sure that these results will be of great interest to the National Health Service, because safety with savings is always attractive. Thank you very much, Jim Jorgensen.
Thank you, Christine.
Radiotherapy is the use of high-energy X-rays and similar rays such as electrons to treat disease. Since the discovery of X-rays over 100 years ago, radiation has been used more and more in medicine, both to help with diagnosis by taking pictures with X-rays and as a treatment known as radiotherapy.
Oncology Systems Limited is the largest independent supplier of radiotherapy equipment to the NHS and private sector in the UK and Ireland. After surgery, radiotherapy is the most commonly used treatment for cancer and the most successful, and for all forms of treatment, it's the most cost-effective. To deliver a course of radiotherapy requires a lot of preparatory work, which requires, for example, specialised software, a range of accessories, which are usually unseen by the patient, but which culminates in a daily course of radiotherapy treatment on a treatment machine. At OSL, we provide all of this equipment, but we're particularly privileged to supply the most advanced mainstream radiotherapy machine available in the world today, tomotherapy. Tomotherapy, which is manufactured in Madison, Wisconsin by Tomotherapy Incorporated, represents a true paradigm shift in radiotherapy, having treated its first patient in 2003 in Knoxville, Tennessee. Why is tomotherapy unique? Well, it delivers unprecedented accuracy and precision and has particular safety features. Unlike linear accelerators, machines that were invented in the 1950s and still in use today, Tomotherapy is based on modern helical CT scanner technology. It delivers radiation as it continually rotates around the body in a helix with ultra-fast changes in radiation beam intensity. This intensity modulation, or IMRT as it's called, is 100 times faster than other machines and results in more precise shaping of the radiation to match the intricate shape of the tumour and results in fewer side effects for the patient. This also results in less ongoing costs for the health service.
The tomotherapy unit, when it was introduced, was part of a research study within the department, but very quickly proved its worth, and we routinely now use it for treating our head and neck patients, very aggressive tumours which would have been a challenge elsewhere on conventional linear accelerators. The patients may not have actually had radiotherapy because it would have been impossible to deliver. Tomotherapy gives us the opportunity to actually be more prescriptive to the patient and allow us to treat these more difficult cases. The unit itself has also broadened the choice that is available to the medical staff within the department about what type of treatment they wish to deliver, but it also has been driven by patient demand and patient choice. One of the things we have noticed over the last few years is actually patients are much more aware, much more educated about the techniques on offer, and routinely we are asked by the patients if we provide a tomotherapy solution for their tumour type. This has meant that we have taken referrals from all over the UK, including Scotland and Wales on a regular basis, and even from overseas, because we have been the only NHS trust for some years, or for the first 2 years of practice, which is now changing, but that has meant these patients have come to us rather than going to the private sector. After 12 months of clinical practice of the first unit, we were able to choose a second tomotherapy as a second machine, because we felt that it would continue to complement the service that we provided here at Addenbrooke's. It allowed us to continue on along our programme of IMRT and IGRT, and the tomotherapy solution offers an integrated system which you can use within your service effortlessly and seamlessly.
Tomotherapy has, I think, some really important benefits for the NHS as a whole. The first thing is that it provides for the image guidance with IMRT capability in an integrated way. That's been really important in focusing people's attention on the need for these technologies, and it's made the other manufacturers sit up and take notice as well of where they were doing too little in the marketplace. Tomotherapy seems to be very straightforward for patients. They're familiar with the general design of the machine, the circular design, which is like a CT or MRI scanner, of course. And actually the way that it's used here, the patients don't stay in the room for long enough to get bored or upset by it. And my perception is that patients find it very straightforward, in fact. Actually, we treat even some patients who are children on this machine, and if they can manage it, then that's also very good. And overall, I think that we believe that there is a reduction in side effects compared to conventional forms of radiotherapy, and that patients perceive that and perceive the technology as providing something for them, as well as experiencing that in a real biological sense.
One advantage of the streamlined process of tomotherapy with having one operator station is that we can actually treat up to 65 patients at present on our 2 tomotherapy units. Our patients are in a 12-minute time slot, so we can treat between 4 and 5 patients an hour, which is very comparable to any other treatment delivery. We here at Addenbrooke's have seen a number of software and hardware developments throughout the last 2.5 years of using tomotherapy, which have helped us again to improve the process for our patients, to streamline the process, and to ensure that our patients have their treatment delivered quicker, so they're not in the room as long and they can get on about with their normal lives.
One of the key features is that we can treat patients that otherwise would have been untreatable. We had a look at our first 100 patients treated on the first Tomo unit, and we estimated that 5% of those patients, that's 5 out of 100, would have been untreatable without these technologies. So that's a very important aspect. Now, some of those patients would receive treatment for palliation of symptoms which otherwise wouldn't have been attempted or offered. And some of those patients were treated with curative intent, where the treatment simply wouldn't have been possible. This actually provides for the very best X-ray radiotherapy that's available anywhere in the world on any platform, and that delivers outcome improvements for patients in my view. Tomotherapy is a fantastic tool for doing image-guided IMRT. Of course, what I'm really talking about is the opportunity to provide access to those technologies. But in thinking about that, one needs to make absolutely certain that the machine will do what it says on the tin. And tomotherapy is extremely good. We can image every patient every day, and we can do the imaging every 15 minutes or so, all through the day. And the integration is fantastic. It shows that this machine was designed from the bottom up, actually quite a short time ago, and it really shows in the treatment design and the speed of the integration and operation of the unit.
With over 900 scientific publications today showing that tomotherapy is superior and flexible, we want to ensure that the public, commissioners of healthcare and other medical professions clearly understand how tomotherapy today is providing the most advanced radiotherapy and yet the most cost-effective treatment of cancer available.
We can treat patients that otherwise would have been untreatable. This actually provides the very best X-ray radiotherapy that's available anywhere in the world on any platform, and that delivers outcome improvements for patients in my view.
1 in 3 people will develop cancer at some stage in their life, and more than half of these people will be treated with radiotherapy. Yet radiotherapy is still probably the least understood form of cancer treatment, despite the many recent advances in speed and precision and increasingly impressive reported outcomes. Varian Medical Systems is the world's leading manufacturer of medical devices and software for the treatment of cancer and other conditions with any form of radiotherapy, whether it's conventional radiotherapy, radiosurgery, proton therapy or brachytherapy. More than 100,000 people a day are treated worldwide on Varian's equipment, so we're a company that touches many people's lives, including the patients here at Ipswich Hospital in the UK, which has a long and proud tradition of offering the most advanced treatments for patients in the local area.
Varian Medical Systems are dedicated to providing the most advanced, efficient and cost-effective forms of cancer treatment. A linear accelerator like this, for example, will cost in excess of £1 million, but it will last 10 years and it will deliver over 100,000 treatments in that 10-year lifetime. The cost of healthcare is a major consideration for economies around the world, and we at Varian Medical Systems strongly believe that developing economies should not be deprived of the most advanced treatments that are available in developed economies. Technological developments are driven by clinical need. TrueBeam, for example, will permit clinicians to use radiosurgery to efficiently treat tumours that may have been previously considered either inoperable or too difficult to treat. The result can be a reduction in the cost of long-term care.
This is the treatment planning system, and it's on this computer that we actually tailor the dose distribution to where we want to treat in the patient. Here we have a prostate patient. What we're trying to do is make sure that the red area is the area that gets the prescribed dose, the dose that the clinician wants to give it, while we're avoiding the other coloured areas, which are our organs at risk. So in a prostate patient, that's areas like the bladder and the rectum. So we're trying to conform the treatment precisely to the target volume and making sure it gets the dose that has been prescribed. On the treatment planning system, we can visualise the doses and the areas where we want to treat on a CT scan of the patient. So here we have a CT scan of a prostate patient, and we have a dose colour wash showing where the dose is in relation to the prostate, which is the red contour on here.
I got throat cancer, and it was November. I had 3 bad teeth, and I had a hurt when I swallowed, so I presumably thought it was the teeth. Had them out. And it seemed to stop, but it was around about late December when every time I swallowed it hurt. Went to the doctors, they referred me here, and that's when they diagnosed it. Okay. The only way it's affected me really is difficult to swallow, and obviously I've got a hard sort of voice, but otherwise no problem. Well, anybody who's going to have it done, just don't be frightened, go through with it, and just try and bear it if you can. And I think if you're strong enough, you'll overcome it.
Rapid arc really does revolutionise the chance of improving the patient experience, but also ensuring that actually the full technical armamentarium is utilised. Rapid ARC gives me the reassurance that the patient's on treatment time is minimalised, which gives me the reassurance that patients have the least opportunity to move. But in addition to that, we can actually dovetail image-guided techniques, which again give me the reassurance that my treatment is being delivered as precisely as possible. My institution has really been at the forefront of delivering technically advanced radiotherapy since I arrived here 11 years ago. We commenced our intensity modulated radiotherapy program in 2001 and have really introduced it incrementally, starting off with some tumour sites and really cascading out to other tumour sites. We've been very keen to cascade the results out to our stakeholders presenting at scientific meetings, really to ensure that others learn from our experience as well as for us to learn from other people's views on our technical implementation program. We've really seen rapid ARC and image-guided techniques as a natural evolution in that process, and we're really continuing with our implementation strategy of not simply using the techniques across all tumour sites, being very selective where we want to use it, where we feel clinically it's most appropriate.
TrueBeam is Varian's latest medical linear accelerator, which can deliver treatments up to 50% faster with a dose rate more than double the maximum output of the next best device. Faster treatments allow for greater precision as there is less time for the patient to move during the treatment, as well as making treatment a more comfortable experience. With TrueBeam, much greater precision is possible, resulting in even fewer side effects. For clinicians, there is up to a 5-fold reduction in the number of steps needed for imaging, positioning, and treating patients, making the treatment process simple, fast, and precise. Complex radiosurgery that typically would take up to 40 minutes to an hour can now be completed in just between 5 and 20 minutes.
The greater the precision and effectiveness of radiotherapy, the less likely patients are to need access to invasive surgery or systemic chemotherapy with all the side effects and costs that those treatment modalities involve. All cancer patients deserve access to the best treatments available, and radiotherapy has developed into a fast, powerful and efficient way of killing tumours while protecting surrounding healthy tissue and organs. Varian's mission is to help save an additional 100,000 lives per year by developing fast, precise and efficient radiotherapy systems that enable more people to gain access to the most advanced treatments available.
We hope this programme has gone some way in detailing how technologically advanced medical innovations are helping in the delivery of treatment of patients with cancer. As we've seen, BD Medical, Varian Medical Systems and Oncology Systems are leading the way with technological advances which are making a huge difference to oncology treatments and outcomes. I'm Georgina Burnett and you've been watching NHS Advances in Oncology.